what the post-treatment size is, and that also is an indication of treatment response. So moving on to the T stage, and we talked about it a little bit on the whole slide image. So this is the histology of common histology for most GI locations. You have the mucosa, submucosa, muscularis propria, subserosa, and serosa. So except esophagus and distal rectum. So when you have mucosal involvement, it is PTIS in the colon, submucosa T1, muscularis propria T2, subserosa T3, and then involvement of the serosa is T4A. So again, here's an example. So on grossly, you might see areas like this on your external examination. So when you see this type of puckering or little bit of hemorrhage, mucin, right over where you can palpate your tumor intraluminally. So it is very important to sample this area, take multiple sections from there, because that is likely where your serosal involvement will be demonstrated. So sometimes serosal involvement may not be as obvious as we saw in this case, right? So what are the situations that you can encounter? Sometimes you may have only blood between the tumor and so-called ink. I think people have a little bit of a disagreement on whether you should ink the serosa or not. I think rightly many people advocate that not important to ink because you can see serosa histologically, we can identify. So what's the point of inking? But I find it useful to ink it because when you are struggling whether the section is complete or not, having ink at the leading front is very good to have, because then you know for sure that your section is complete, right? And then the other fact is here you have blood over the serosa, and then here you have ink, right? So you know that between the tumor and the ink there is only blood. So definitely the serosa has been destroyed there. Again, if you see only like inflammatory cells between the ink and the tumor, again it is considered serosal involvement. And similarly here you can see it's very close. People may debate whether this is actually T4A or not. I would just call it T4A because if you do like uh, uh, the 50 levels on this block, then you will demonstrate this at some point. It's reasonable to do 1 or 2 levels and see if you can actually demonstrate. But if it doesn't work out, then I think it's the best to call when it's so close to the serosa. It's better to call it within a millimeter. You just call it serosal involvement positive. And then what do you do when there is a tumor perforation, right? So here's an example where the tumor went through the serosa. Actually, there is a perforation at that site. So it's good to ink because that makes you certain that this is exactly the tissue edge you are looking for. And then you have, ink and tumor on it. So no question that this is T4. Lymphovascular invasion, we tend to classify it as small vessel and large vessel. So small vessel involvement is a risk factor for lymph node metastasis. Large vessel involvement is a risk factor for liver metastasis. It's going in the veins and going straight for the liver in that case. So large vessel involvement can be subclassified into intramural and extramural involvement. So intramural means it is confined within the muscularis propria, and extramural is it's beyond the muscularis propria. So here's an example of a small vessel invasion. Here are some examples of large venous invasion. So what can we do when we are worried about large venous? It can be a little challenging, right? The clue here is to find orphan arteries. So you have an artery here. I mean, in this case, there are multiple vessels, but like right adjacent to an artery, you see a rounded focus of tumor without an obvious vessel wall, maybe a little bit here. So this is highly suspicious for venous invasion. Similarly, in this case, right, you have a thick-walled artery here, and then next to it, you have a nodular deposition of carcinoma and no vein. So this is again called orphan artery sign, and this is pretty diagnostic of large venous invasion. And then you can use elastic stain. Now, elastic stain interpretation can be a bit tricky. Sometimes the tumor just completely destroys the vessel wall, and the elastic fibers may also not be preserved at the periphery, but sometimes you can demonstrate the elastic fibers at the edge, and that is a useful clue to know that there is venous invasion. Perineural invasion is also good to document, though not really that prognostically significant like LVI and large venous invasion. So the good place to look for perineural invasion is around the plexus, right? So you look at the plexus between the circular and longitudinal layers of the muscularis propria, and you can find that the tumor may be creeping along the nerve plexus. So that is, here's an example of a perineural invasion. So going on to tumor budding. So this is a little bit of a controversial area, right? People have defined, there were many ways in which people assess tumor budding. And then finally, a group of people came together, formed a tumor budding consortium, and told us how to do this in a consistent way. So we follow the tumor budding consortium guidelines on this. So what is tumor budding? So we saw that in our case, at the leading front of the tumor, we can see some small clusters and single cells which are invading into the stroma. So these are called tumor buds. So definition of a tumor bud is either single cells or small clusters less than 5 cells each, right? So what if you have 6 cells, 7 cells? Well, technically, that is not a tumor bud. They are called poorly differentiated clusters. They are also prognostically significant, but not a part of the tumor budding grading, right? So these are all a part of a phenomenon known as epithelial mesenchymal transition. So that is what tumor budding and EMT itself, epithelial mesenchymal transition itself, is of prognostic value. So the theory is that the tumor epithelium is sort of on its way to become more like acquire a mesenchymal or poorly differentiated phenotype, and that is what is causing these buds and single cells. It's like a transformation, a stage of transformation. So it is assessed at the advancing front of the tumor. It is an adverse prognostic factor and predicts the risk of lymph node metastasis. So the ideal way to do this is to evaluate this in a hotspot area on 20x. But how do you know what is your hotspot, right? So when you start looking at a section, you think that there is tumor budding. You scan through the section and try to see which might be the hotspot, right? Where is the maximum density of your tumor buds? And ideally, you would like to, look at 10 fears, do a rough estimate on 20x before determining which is your hotspot, and then do a proper count on that hotspot area. So, and then you only do it on H&E sections. You don't want to do it on cytokeratin or any other stains. So, and then this is also very important that in the field diameter of your microscope. So when you look at these papers, they have a nice conversion table. I don't think I included the conversion table here, but depending on your uh, you know field diameter of your microscope on 20x, you may have to tweak your hotspot grading a little bit, how many fields you need to count, right? So the tumor budding, once you have your tumor budding count, you can classify it into low, intermediate, or high for reporting. So if you have up to 0 to 4 tumor buds in the hotspot area, it's low budding. 5 to 9 is intermediate, and high is more than 10. But there are certain caveats that you need to know before you do your tumor budding reporting. So if there is too much inflammation, and sometimes you can see tumor glands being destroyed by neutrophils at the invasive front. So in those cases, don't do your tumor budding, you can say that inflammation precludes tumor budding assessment because that will give you a falsely high tumor budding score. Don't use immunostains to do this because the scoring criteria was validated on H&E. And then for medullary and micropapillary carcinoma, again, we do not do tumor budding score. Medullary because it is a pushing invasive run, not infiltrative. So tumor budding, ideally they should not have tumor budding. And micropapillary is the same spectrum as tumor budding, but because the papillae are larger, right? And then the whole prognostic implications of micropapillary carcinoma again is bad already. The tumor budding scoring does not apply to this tumor. And then it is debatable whether neoadjuvant cases should be scored for tumor budding or not. Some recent papers have suggested that in treated rectal cancers, high tumor budding after therapy again has bad prognostic value. So it's not in the guidelines yet. Guidelines still say not needed to do in treated cases, but it may change down the line. So again, in treated tumors, if you do not see a macroscopic tumor, submit the entire tumor bed. Look for treatment-related changes, right? So you will see stromal fibrosis, acellular mucin, thickened blood vessels, sometimes hemosiderin and inflammatory cells, histiocytes. So all of these changes suggest that this is the tumor bed because it's important, right? If you cannot see a tumor and you're sampling a certain area and you don't see therapy changes, it means that you may have actually not sampled the tumor bed. So you have to go back to the specimen, look carefully again, and make sure that anything that looks like a scar or fibrotic area is sampled. So having these changes is very helpful. It makes you certain if they had used a tattoo at any point, then that is extremely helpful again to localize the tumor site. But these changes are pretty consistently present and help you determine tumor bed. And then when you have tumor present or not, you still have to do like a tumor regression staging, right? So for treated cancer, you want to assess how much response this tumor has had to the neoadjuvant therapy. So if you don't see any viable cells in the tumor bed, then that is considered complete response and the score is 0. If you see very few scattered single cells or very small clusters, rare groups, that is near complete response, that is score 1. Sometimes you may see reduced cancer, residual cancer, but it is more than single cells or rare cells. So like this, you have some gland. It's not like all wall-to-wall cancer. There is a lot of fibrosis and this type of inflammatory response, which makes you think that this is a tumor bed. So the stroma looks responsive, and you have little bit of tumor. So that is partial response, score 2. And then sometimes there may be a lot of tumor left over, so that is poor or no response. Some tumors may not respond at all and there is no evident regression, so that is again no response or score 3. So that was about the tumor. Also good to look at the precursor lesion if present, so you note that whether you have background of adenoma, villus adenoma, tubulovillus adenoma, TSA, SSA, or a hyperhematomatous type of polyp. So margins are very important, right? So you do, for your standard cases, 2 mucosal margins, proximal, distal, and then you also look at the radial or mesenteric margin or the CRM, depending on the location. So here's a good schematic showing that depending on the area of colon you're dealing with, you may have different radial margin, right? So if you have a part that has some retroperitoneal surface, right? So example, cecum. So you will have one bare area on the posterior side, but rest of it is covered by serosa. So this is your CRM or radial margin, and then this will just be the serosal surface. For the rest of the colon, most part of it, you have a very thin part which connects with the mesentery, right? So most of it has serosa around, and then it reflects around the mesentery. So this part is your mesenteric resection margin. So wherever your tumor is, you give your closest mesenteric resection margin. That may also have a vessel, and that's the vascular margin, closest vessel. And then in the distal rectum, you have no serosa, so you have a circumferential resection margin. So here's again just a photograph showing, proximal mucosal margin. You want to take a nice full thickness section, distal margin, and then in this case, your circumferential margin will be with respect to this part which does not have serosa and is only inked. And here's an example of the mesenteric margin. So you have, your mucosal margins, and then this part just has mesentery, and this is where the mesentery was cut by the surgeon. So you can take an en-face section of this. If it's very close to the tumor, you can show the a perpendicular section as well. So yeah, margins, you take the closest margins, obviously, and you document which is the closest margin, give the distances, give the distance to the radial margin or for the rectum. And then for the rectum, the distal margin distance is also important and should be noted. And then if you think any margin is positive, you specify all the positive margins. And then you also assess the margins for dysplasia. So here's an example. I think this is from the stomach, and this is a nice en-face section that was submitted. And then you can see how this tumor is so bland. This is a very, very bland, almost histiocytoid looking adenocarcinoma of the stomach. And you can have this type of cancer submucosally present at the margin. It will not be grossly visible, or frozen section. If you get frozen sections of margin, these would be very challenging to pick up on frozen section. And then coming to the lymph nodes, so uh, we talked about the T stage. The N stage is determined by lymph node positivity. So it is important to thoroughly sample all the regional lymph nodes. It's important to know which are the regional lymph nodes for that particular site, right? Especially, in the stomach, you have so many lymph node levels. So always good to know the location of your resection, your tumor, and then what would be the regional lymph nodes for that site. And similarly for here, sometimes, the surgeons intraoperatively may pluck out an obviously positive lymph node and submit it separately. So important to know where that lymph node was located, because if it is regional, then that is N. And if it's distant, non-regional, then it becomes a metastatic focus. So that has to be considered in your M stage and not N stage. So it's important to know what are the regional lymph nodes for that particular site. And again, the CAP guidelines have very nice diagrams showing regional lymph nodes for every area. So, and then we need some certain number of lymph nodes for adequate assessment and adequate end staging. So the cutoffs proposed for lower GI tract colorectal specimens, you have to have at least 12 lymph nodes for adequate end staging. The rule is to submit any visible lymph node. So you have to find as many lymph nodes as possible. If you find 12 lymph nodes, you do not stop there. You still continue to look for lymph nodes, but so 12 is the minimum. And for stomach, it is 16. And you have to know how many lymph nodes were examined and how many are positive. It's important to keep a good documentation of how many lymph nodes are submitted. If you're bisecting the lymph nodes, make sure you note that in your growth description, because you don't want to overcount positive lymph nodes when bisected. So all those things again come down to how well you document your gross findings and inspection. And then coming to tumor deposits, this is again an evolving concept. It will again undergo some changes in definition. What we know is this is a focus of tumor that is away from the main tumor mass and is present in the pericolonic fat. So oftentimes you encounter these foci in your lymph node dissection, right? So this will be felt as a white area while you're grossing and you will submit this as a lymph node. But when you're looking at it under the slide, you don't see a lymph node at all. So you see a focus of tumor in the pericolonic fat. There is no lymphoid tissue. You don't obviously see a vessel around it. So this has kind of, you know, how are these tumor foci getting there in the pericolonic fat, right? So the theory is that these are foci of tumor which have completely destroyed the lymph node they metastasize to. So there is no definitive lymph node left over. Uh, and or it is either a focus of large venous invasion and the tumor has completely come out of the vessel and destroyed it. So it is possible that this was a large venous invasion. We have an artery here and it has completely overgrown the vessel and it's not possible to determine whether this was a lymph node or a blood vessel, and then you just call it, so it's a wastebasket determination. Basically you call it a tumor deposit. So documenting tumor deposits is important, and also I think going forwards having documenting the number of tumor deposits will be important. So having tumor deposits in absence of positive lymph nodes will bump the end stage to N1C. If you have lymph node metastasis, then it doesn't really matter in the current staging system. So you will still do the end stage depending on your lymph node number, but that will stay probably change down the line depending on the tumor deposits that you find. But for now, uh, if you have lymph node positivity, it is N1A or N1B. If you have tumor deposits, it's N1C. So that is important to know. And then distant metastasis includes metastasis in the liver, either peritoneal metastasis, other organ metastasis, and then non-regional lymph nodes as well. So I just wanted to summarize like the staging for all tubular GI organs. T stage depends on the extent of invasion of the bowel wall, except anus, where it depends on the size. And then the T4 status will change depending on the peritonealization status of that organ. So, T4 for esophagus, because it does not have a serosa, it's, invasion of the pericardium and pleura, whereas in the stomach, T4 is involvement of the serosa. So you have to keep that in mind depending on the organ. So again, this is a diagram showing the same. When you have, the an organ that has serosa, it is T4. When there is no serosa, presence in the adventitia is still T3. So this is just a summary, and I'll share the link for this so that you can compare. So how the staging changes depending on the organ that you're examining and what are the things that you need to look for. I'm not going to go in the details of this right now. So what about GIS? So that is something that differs by the area of the GI tract you're examining. So for colorectal cancers, involvement of the lamina propria and muscularis mucosae, but not submucosa. So just lamina propria and muscularis mucosae is called PTIS. So that is the intramucosal carcinoma. And once it goes beyond the muscularis mucosae, it is PT1. But if you go to the upper GI tract, PTIS is actually just intraepithelial tumor, which is equivalent to high-grade dysplasia. If you have lamina propria invasion, muscularis mucosae invasion, it becomes your PT1A tumor. So you have to keep that distinction in mind. So, use the term intramucosal carcinoma with caution, because that would change the staging depending on whether you're dealing with colorectal or upper GI tract site. And then you obviously report on the background process if you see IBD or IBD related dysplasia. and then diverticulosis in the upper GI tract. You also note H. pylori status or background stomach. So, and then it is also important nowadays to report on biomarkers. So, in the colorectal cancers, now it is standard of care to test for mismatch repair IHC, that is done routinely for every colon cancer. Additionally, for advanced colorectal cancers, you may need to report on HER2 status as well. And then molecular testing for KRAS and RAS-BRAF is also standard of care. So, and then in the upper GI tract, HER2 status is more important. In the esophageal, you have PDL1. So it varies by the organ site that you're dealing with. So here's an example of mismatch repair IHC. So this is a poorly differentiated colon cancer. And then we have the 4 mismatch repair IHC markers here. So this tumor, normal expression is positive expression in the nuclei. So that is intact nuclear expression. So this tumor is actually showing loss of MLH1 and PMS2. So, and then we have specific algorithms for further testing once we know which mismatch repair protein is lost. If they are all intact, that is MMR intact, you don't need to do anything further. If you have loss of MMR proteins, then you have to do further testing to determine the mechanism of MMR loss. So this is again, an interpretation guide as to how to what to do once you have loss of mismatch repair proteins. I'm not going again in the details of this because we're getting close to time, but happy to share this with you, and feel free to ask me any questions if you have related to this. This is one of my favorite topics actually, so happy to give another talk on this later. But and then HER2 again, important to know that the criteria for reporting HER2 are different from breast. So the way to assess is also different. So in breast, HER2 is assessed, HER2 positivity is assessed in like circumferential membrane staining, whereas in the GI organs it is basolateral or complete circumferential. So there is difference in the way we interpret the staining and also the percentage. So keep that in mind while you're doing your HER2 assessment. And then talking about the local excisions that I touched upon earlier. So here's an example of a EMR specimen. Sometimes they will come oriented also, so you'll know which is proximal, distal. And so you have a mucosal margin here, and then the deep margin will be the part that was excised from the bowel. And it's good to ink the margins, and you can either submit this entirely with respect to the margins or at least sample the closest margins and the tumor. The deep margin is much more important in these cases than the mucosal margin. So again, having deep margin involved would require a more extensive surgery. So something that you have to evaluate very carefully. So essential parameters in these local excisions are again tumor type and grade, size, extent. Again, prognostic factors like LVI, tumor budding are very important, because if you have any of these adverse prognostic things in your tumor, then you have to report that, and that may change how the patient is managed. They may have to go for a surgery. And then margin status, obviously, you will report. So here's an example of an EMR. Or actually this was a submucosal dissection, because you can see the muscle as well. So this was an ESD specimen. So you can see the red areas, they are the mucosal margins, and then this is the deep margin. And it's good to ink, but also to know that ink can flow. These are small specimens and ink can overrun. So it's always important to correlate your ink with the cautery changes. So when you have cautery changes, they take predominance. So if you see tumor at cautery, that is much more important than seeing tumor at ink, because ink can flow and involve different areas. It may not be the true margin in every case. So cautery changes are recognized by this, dense eosinophilic change in the tissue at the edge of the tissue that where the cautery was applied.